The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Morning, George. It's Tuesday morning and we're snowed in Washington, D.C.
Yeah, luckily in Long Island, there was just a little flurry on the ground. Glad that we didn't cancel office hours. Today, we have a great guest, Dutch Rojas. The topic of discussion for today is going to be very interesting. The David and Goliath of the healthcare revolution, when private practices and physician-owned hospitals return fire. Take it away.
Dutch Rojas is a healthcare entrepreneur and innovator with over 2 decades of experience in the industry. He currently serves as Senior Vice President of Direct Healthcare at Naomi Health, where he focuses on simplifying and reducing the cost of healthcare services. Dutch has been a strong advocate for private physicians, ambulatory care centers, and physician-owned hospitals throughout his career. He emphasizes the importance of price transparency and free market competition in healthcare. In addition to his role at Naomi Health, Dutch co-founded FICAP Fund, which supports new healthcare startups. Welcome, Dutch. It's great to see you.
Great to be here. Thanks for having me.
Dutch, we usually start the podcast with, why did you become a physician or a pediatrician? You're
Neither. No, I'm not.
You're a special guest. So why in the world are you involved in healthcare? It's like a minefield. What is it that you do? Tell us about it.
I'm a mere accountant. No one special. I got involved with healthcare. I moved to the United States in 1990 to play soccer at a small college. And it is a D1 college, but it's small. And they sent you, it was a Protestant school, they sent you on mission trips. And one of the trips was a medical mission trip. And so we spent a significant amount of time trying to get down the Amazon, get on a couple of bush planes. Took us about 5 days. Lo and behold, I'd never seen something that you guys know a lot about. I'd never seen a portable surgical center. And we got to this kind of plateau place, and we're in the middle of nowhere. And I watched about 25 physicians and about 7 dentists do some work that will make any grown man weep. And I watched them work on people. I watched people from all over the place just show up. I was like, where are these people coming from? And they showed up, and physicians treated them, and dentists took care of them, of their children, the women, the men. Most of the men were miners in the Amazon, mining for gold. And I was a junior accounting student. And I thought, heck, if I'm going to be this big business guy that I want to be, I always wanted to move to Manhattan, which I ended up doing. I thought, what can I do on healthcare? And that's really what started the journey was, hey, there's a big need and lots of asymmetries exist. And this is what I want to fix.
Yeah.
And where did you move from?
I came here from the Netherlands. That's why.
Wow.
That's why my nickname was Dutch, and then it became my official middle name when I got to be a little bit older of an adult.
Right.
And so what's your crib name?
Yeah, my first name is Niels, Niels. And my problem with it was, one, I got the nickname Dutch right away because nobody could say Niels the right way. And then they could never spell it, right? It's I before E, which is very like when I learned English, it was like I before E except after C. But no Americans prescribed to that rule. They just wrote N-E-A or N-E-I. So that's kind of stuck. And I was like, hey, this is pretty cool. I'm a Dutch kid. So now it's 30 years later. So it's the same thing.
That's a pretty cool name. So let's get an overview of the landscape of healthcare today. Where do you think we are today in healthcare? And what does the future look like?
I think we're on the precipice. I think that we're going to talk about these issues.
Yeah.
But I think we've seen margin compression in private practice, independent practices, you like to say. I think we've seen real big challenges with recruiting new physicians, with retirement. I sat with a retiree yesterday. The practice paid him $2.2 million to retire on his exit. And I just thought to myself, you worked for bleepity bleep 30 years in a practice, and you're getting $2.2 million when you walk out. Like, I thought, well, what a travesty. And why is that? And that's not good for medicine. We can't have doctors retiring on something as small in a retirement package that anybody could get at a big health system times 2 or 3. And so I do think we're on the precipice where we've seen so much push against private practice. When I started, independents were close to 80%. The number slowly dwindled down, and now it's probably close to 25 to 30%, somewhere in there, depending on the area of the country you're in. But I think for the first time, probably started third quarter last year, I saw a glimmer of hope, and I saw some things changing. And I'm hopeful that the pendulum is swinging backwards. I feel like physicians, for the first time, are standing up for themselves and fighting. I know you guys like to see patients and treat them, but I feel like finally we're getting a voice of advocacy and saying, hey, enough is enough, pal. I like that Northwell's making a bunch of money, but guess what? We also have to take care of patients, and we also have to start making some of that money.
What are the problems? There's a lot of market concentration. You write about this, and a lot of regulation that favors the Novas and the MedStars and the Northwells of the country. And there's probably three that you speak a lot about. One is market concentration in the sense of, for example, Innova in the Northern Virginia area owns 85% of the beds. In Rochester, there's 1.5 behemoth that basically have everything locked down. So there's no Laport, no Quest. Whatever the major health system says is what happens. And then the other area of concentration that was brought about by the ACA is the merger of health plans. So in Rochester, for example, Excellus controls 70% of the market. In Virginia, Anthem Blue Cross Blue Shield controls over 40% of the market. And then there's regulation. Not every state works this way, but in Virginia, there is certificates of needs. So you cannot go get an MRI and compete against Innova and charge $300 for an MRI without Innova's consent. And in Virginia, it's basically impossible to open up a standalone surgical center because the big health systems like Innova and Carillion down south and Centera will block you.
That's right, 100%.
So if you could explain to the audience how that's not good for physicians, but worse yet, that's not good for patients and it's not good for the taxpayer.
Yeah, I think if we break it down into two segments, one would be government regulation compliance, and then the other segment would be business strategies. I harp pretty hard on compliance regulation. What you have, let's call it 10 to 12 rules or laws, federal laws and state laws, that essentially hand the business over to the larger health systems. Now, the good news is there are solutions to all of these challenges. I think we'll see those solutions deployed over the next 3 or 4 years, and I think they're going to cause a massive amount of disruption, not to patients, but to those health systems. And so that's the good news. The regulatory framework, you did a really good job talking about certificate of need, or AKA common laws. The group or school out of Virginia does a really good job reporting that data. And I'm surprised because you have a really forward-thinking governor in Virginia. And it seems to me he just doesn't know what these rules are and he's never heard of them. And I bet if you talk to him tomorrow, he'd go, I didn't even know what this was. Because it seems silly for lawmakers who get up and tell voters, Ro Khanna did this yesterday, and so did Bernie Sanders and a couple of others. And they stand up and they say, our health system stinks. Everybody's paying too much for coverage. And then I've sat with Bernie before, and I go, tell me why you limited supply of physician-owned hospitals during the ACA. Like, why didn't you support that? He doesn't answer the question.
He doesn't know.
He looks at you. I literally had this conversation with him. And then his person walks over and goes, hey, Dutch, this conversation's been great, but we're done. And I'm so disingenuous.
So I'll tell you why Glenn hasn't touched that. I don't know him personally. I'm very good friends with one of the best orthopedic surgeons in the country, Randy Payton. And he's good friends with Glenn. They live in the same neighborhood. They go to the same country club. And so I know that the governor is very interested in all these issues. But whenever this is brought up, Innova, Carillion, it's now the Medical College of Virginia in Richmond, sit at the table with the governor and his aides and say, hey, if you squeeze us hard, we're going to have to terminate 15% of our workforce because we're barely making it. Our margins are so tight. And remember that 50% of the workforce is all female, and they have nice middle-class jobs in every county in the Commonwealth. and they won't be able to find jobs. Do you think that in Virginia you can't get reelected, but do you think that will be good for your political future? And that's how they break their arm. They just say that.
I don't think listening to a liar speak and say it over and over again makes it true. This is completely false. And these people say the same thing. They go, we have physician-owned hospitals. We have more competition. They'll just cherry pick the cases. They said the same thing about ambulatory surgery centers forever ago. And now we have 6,000 of them. So like the entrenched interests keep saying things and you look at them and you go, oh, you're lying. Like what you're trying to do is save your job. And I don't know why, because how do you sleep at night knowing that you've hurt a bunch of patients? You're an American. You're supposed to be a patriot. You're not supposed to be committing treason to this country and the people that live in here. Like, be an honest guy, make a living for something honest. Stop taking money out of people's pockets you don't deserve. And that's what these large health systems do.
So for those who don't understand, what is the difference from the cost perspective?
Yep.
Say an imaging center in Burke, Virginia, that's owned by radiologists, or a eye surgical center in Burke versus Innova's outpatient services. What is the difference in cost, and why is that not good for the customer?
The difference in price is going to be drastic, 10x. So an independent radiology center ought to be able to do an MRI. And this is across the country because we have contracts with people across the country, right? Some 6,000 centers or something. And it should be $300 to $550, somewhere in that range, right? Of course, there's a mean and an average. And then the large health systems, not independent hospitals, the large health systems will receive, not charge, $4,000 to $6,000. And they'll get it all day long. And the reason that is because they have so much market dominance. When you look at large carriers, what do they want to do? Do they want to call every Tom, Dick, and Harry? No. What they want to do is they want to call a health system and they want to go, do you meet my network requirements? The ones that are done by state law and the ones that are done by federal law. And then, okay, you meet those. So we're just going to give you all the business. And then they'll do dandy deals. The way that carriers make money, and I'm sure your audience knows, is they make money through their PBM that they own, and they make money through Medicare Advantage. And I've sat in on these meetings, so please believe me. What happens is a health system will say, we have $350 million that we need to cover this year. And they'll say to UMR, United Healthcare, Aetna, and they'll say, how are you going to do that? And the carrier will say, here's what we want. We want 80% of Medicare on MA, and then we'll give you 300% of Medicare on employer plans because we don't give a crap about the employers anyway. And then we got to have the PBM. And so what happens is all these health systems just use their market power to destroy the little guys. And the little guy calls United and goes, I do a really good job and I'm really trying to lower healthcare expenses. And I just want $400 for my MRI. And they go, suck it, man. We don't care about you. And we don't want anyone to go to you. We want premiums to go up. Like health systems want more expensive things. They'll complain about their costs. They're lying. They've never done any cost accounting ever. I am an accountant. I know cost accounting when I see it. They want their costs to go up. They want their prices to rise. And because they want premiums to go up. And this is a nice little hand-in-hand deal. The American people have been duped for a very long time.
So let's dig deeper into that, because it's the same problem as you find in some poorly run states like New York, where the unions make deals with the government. And,
for sure.
And both sides of the table don't have the interest of the taxpayer. And there is really very little health insurance in the U.S.
That's right.
What United Healthcare is, and we can explore that a little more, is multiple lines of business. But on the what they call insurance, they're a claim processor, and they provide a network of physicians.
That's right.
And for that, they charge 15%. And so the more the Medicaid of Virginia spends on Medicaid, the more that 15% bucket grows.
That's right.
The Medicare Advantage is even worse because they, especially United Healthcare, if you read the journal recently, they fake diagnoses. For example, my favorite one is the patient has diabetic cataracts and they had their cataract surgery 2 years ago. and they get an additional payment for Medicare. It's $2,000 per patient, and they pocket that delta into their coffers.
And Dr. Bravo, the problem with that isn't one-sided. Yes, am I mad at United? For sure. And a lot of physicians are. But guess what else I'm really mad at? CMS. Who at CMS decided that this was going to be a good deal? Right? When I look at the individual who runs CMS and then look at the attorney, if you could call them that, at HHS, I go, these people made these deals for typical Washington reasons. They want jobs after they leave office. And what a better way to get a job than offer United Healthcare billions of dollars. You can't read these agreements because they're not public. But if you read them, you would see, any normal idiot would never have signed this deal. What's also sad is there's no lawmakers on the Hill, and I'm on the Hill every month. There's no lawmakers on the Hill going, why can't we pressure CMS? They have no power over CMS whatsoever.
Not in their radar. And so then the third bucket is the self-insured, I don't know, Boeing or Apple. People don't realize that when you work for Apple and you go get a $3,000 MRI, United Healthcare is not paying for that MRI. If Apple's paying for that MRI, and then United Healthcare is taking 15% of that $3,000 and put it in their pocket. And they're worse than a lawyer. And then people are like, great, I went and got an MRI. I didn't have a copay. And I look at them and I go, what was your pay raise last year? Because your company couldn't afford to give you a better wage because their healthcare spending is out of control. But from United Healthcare's perspective, why would they not want that MRI to cost $3,000? That's $300, $450 in their pocket. If they can get it down to $500, now it's only $50 in their pocket. They would be suicidal to do that from a business perspective, right?
Yeah, and if you I've had these conversations over the last 27 years. Every single officer of a corporation has a fiduciary obligation to the corporation itself. And so if the CEO of the big United Healthcare, not United Healthcare, said, hey, you know what, American people, here's what we're going to do. Because we have billions and we're running this deal. We're going to cut all the premiums in half. Guess what? He'd be civilly sued, probably go to prison for some criminal deal. It's not doable. The only thing that changes this narrative is competition. And the only people keeping markets in healthcare from being competitive is the United States government, the lawmakers who get lobbyist dollars, right? Because that's all those guys care about. And then it's the health systems and the banks. And so you've just got this massive problem. Again, though, all of this can be squared up. All right. So we do need some relief from lawmakers, and we do need some physicians to do a couple things. But other than that, I think we can beat the pants off these health systems. I don't think they're as powerful as the independent physicians are.
And so tell me about the PBMs, because that's another fun line of business that United Healthcare is on. How do they make money?
They make money the same way. Look, the number one way they make money is, one, in Medicare, they don't have to negotiate. So you're a pharmaceutical company, you're Eli Lilly in Indiana, in the great state of Indiana, right? One of my favorite states. And you say, I'm going to release this drug and I'm going to charge $1 for this drug. The PBM says, no, we're not going to do that. We'll take your dollar, you'll sell it to us for $1. And we're going to charge $500 for it. And we're going to get it. And there's no one that can tell them different. The federal government, again, CMS, made a deal to do this and just write a blank check. Again, when you look at the number of employees going back and forth between carriers and the bureaucracy in Washington, D.C., not far from where you are, this is just what happens. They just trade jobs. If you're really good at healthcare policy, you're going to end up at an insurer. And they're going to pay you a lot of money that you'd never thought, I'm going to make $500,000 in a year. Guess what? You are now. You just handed those guys $1 billion. It's a big problem.
And so the PBM, so to just level set, for example, Ozempic and Mounjaro, Eli Lilly makes Mounjaro. They sell it for about $300 for a month worth. And then the PBMs sell it for $1,200, $1,300 a month.
That's right.
And that they pocket that. And because of the ACA, BM's a different bucket. So it's not beholden to the 15% profit rule.
Yeah.
And so they can make as much profit as they want.
That's
And if
right.
that wasn't enough greed, then United Healthcare is the biggest employer of physicians in the country.
That's right.
And what do they do?
Let me just say something really important. MLR, right? You've got small group that it applies to and large group. Small group, 15%, large group, 20%. Or maybe it's vice versa, but it's one of those. And so you've got some differences. On some plans, it's 20%, some plans 15%. Now, MLR does not apply, the minimum loss ratio does not apply to Medicare, Medicaid, or self-funding. So the good news is MLR does apply to about 80 million people in the country. It doesn't apply to self-funding, which is about 105 million people. It doesn't apply to Medicare and Medicaid. Now, Medicare and Medicaid have different standards that might look similar on a policy based on MLR, but the minimum loss ratio only applies to those guys. The good news is that they won by doing that. If I was them, I would love it. MLR. Hey, I could just raise the price from $1 to $5 and I'm getting 15 or 20%. And now I get more. It's pretty great.
Yeah.
If you're them, this is the greatest deal. I wake up every day with a big grin on my face going, we're just taking money like it's candy.
And they're taking it from premiums on the insurance policies because
That's right.
they increase the health insurance. I'm an employer also, right? So they increase our premiums by 10%.
Yeah, easy.
And they blame it on COVID. They blame it on that's the way it is, the economy, whatever you want to blame it on. Put blame it on.
Yeah.
Yet the reimbursement to physicians
is lower.
Pathetically low.
Yes, because it's
how can a large commercial policy reimburse less than New York State Medicaid for 993?
Because it's doing that for you, the independent, but not for the health system.
Yeah, I've seen that because now I see them on the different doctors.
Yeah.
And my wife went to her OB that delivered both of our kids, was in practice. He did his thing and now he's retired. So now he's taken over by the system.
That's right.
A routine woman's check was like $400 paid by the same insurance carrier that we get.
Yeah.
We use.
No, it's not. But again, you really need market forces to make a change, right? Like everybody says when we used to have stock trading, it used to cost $8 a trade and now it's free. Guess what? The federal government and their cronies didn't step in and say, bro, it's $8. We're mandating that all trades are $8. They said, okay, there's Schwab, there's Robinhood, there's this guy and that guy, right? And they all came in and said, well, we're going to dismantle this whole system. And the free market let it work. And so you went from, when I was coming up, 97, 98, living in the city, trades were $8 to $10. And today they're free. Like Scottrade made it free. Schwab made it free. That's what we need in healthcare. We need to allow competition. And today, competition is very hard because of site neutral payments, because of certificate of need, because of the ACA. Like all of these laws make it really difficult. Like one thing I've never understood is how Peter Stark decided that health systems ought to be able to pay primary care doctors and specialists for referrals. But if you do it, Mr. Independent Physician, guess what? Go to jail. Get in trouble. You took $200 tickets from some rep. Guess what? You're in big trouble. Like, who thought of these laws? And how did they possibly get passed other than complete and utter purposeful misconstruence of the market? These people have absolutely devastated the market, and we have to get it back.
So why do you think physician-led models are important for society?
Oh, let me tell you, the number one, every single study in the country, you can Google it, you can Chat GPT it, you can Grok it, you can do whatever you want. Every single person in healthcare knows that physician-led practices have higher quality outcomes and lower prices. Is that true for every single one? No. But it is the case in the majority. If I say, hey, who does the best total joints, right? It's always private practice guys. They're not in the health systems. They're not in the health systems in New York. They're not in the health systems of California. And they certainly aren't in the mid-continent. We've done massive amounts of studies on all of this over the last 27 years. And you're just going to find that when doctors are leading the race, they do what's in the best interest of the patient, not the bucks. The MBAs, look, I love them. You have an MBA, I have an MSc, right? A Master's in Finance. We're all nice people, but incentives drive the scorecard. And if you incentivize an MBA, right, out of Wharton, really great school, and you say, now listen to me, you screw over the doctors and the patients and you make it $2 million a year for your house in Greenwich, guess what he's going to do? Screw everybody over.
Yeah.
Smoke a cigar and have a bourbon at the end of the night and look at his 2 children and go, man, I paid for your way through college and I love my wife.
And your wedding.
What you're going to do.
And I'll leave you a trust fund. And they say what I say all the time. Don't hate the player, hate the game.
Yeah.
That's what that's
true.
I don't make the rules. The rules aren't fair. I'm just maximizing the profit for the shareholders, which is my job. I'm doing my job well.
The other problem with the shareholder argument, which I really don't like, is I'm the shareholder. Every single teacher's fund, firefighter fund, and pension fund in the country is a shareholder. And one of the big messages I try to get out every year when I do podcasts like yours, or I do all these symposiums is, hey, if you're a practicing physician, you've got to get the word out to these funds where your retirement goes that you're not in these healthcare stocks, that you're not going to support these jagoffs giving $700 million to politicians every year. Like, enough is enough. And you got to stand up and fight back.
And I have one more thing about United Healthcare. So with their...
Just one more? Because we can like 20.
No, but this is just another one that's really egregious. I think they employ 100,000 physicians now, about 10% of the workforce.
Yeah.
And why would they want to do that? So they do that for a simple reason. They pay George 75% of Medicare to see a physical in the office because he's independent.
Yeah.
But they pay their employee physicians, when they negotiate the contract, 300% of Medicare.
For sure.
And they don't give the doctor more money for a salary. They just take that and put it in the CEO's pocket.
Yeah, they got the buy side and the sell side. Why any business person is going to do that? Yeah.
And to your point a little earlier in the conversation, there's all these rules. A hospital can't take me out to dinner. Pharma can't pay me for informing them on this policy. And physicians can't own pharmacies, and physicians can't own hospitals. Hey, the hospitals can own physicians and the insurance company can own physicians, and there's no conflict of interest. There's no problem.
No,
everybody's okay with it.
Everybody knows that that's not true, right? It's like the last 15 years we've lived through. Everybody knows these are lies that will be told. We just have to stand up, be a pragmatic society and go, if it's enough, we're not taking this anymore. This is madness. Look, $24,000. I had a couple docs ask me about insurance yesterday, and we looked up quotes on the ACA marketplace. $24,000 with an $8,000 out-of-pocket max. What do you have insurance for? For what? You're paying $30,000+ for what? For nothing. They're going to deny your claim when you get there anyway. It doesn't make sense, and it's time for Americans to say, I've had enough. This is what I'm going to do. And there's some very pragmatic steps they can take and just start solving this problem.
How do you solve this problem?
By the way, I think it begins with you, not me. I think it begins with you. I think you've got to fix independent practice on a practice level.
Right.
One of the things we started doing, we're doing it successfully in 4 states. This year we'll grow to 10. And hopefully word gets out quicker and people start doing it on their own. Dutch Rojas doesn't need to be the only guy starting businesses. But I started forming coalitions with all the independents in different states. And so what that looks like is you have a practice, and like in New York, let's say between Long Island and North Jersey, right? Like the summits of the world and Jersey City, you've probably got 4,800 independent physicians, right? And so we're uniting those under one umbrella only for the purposes of payroll, benefits, and all the other insurance lines. And what that does is it takes someone who has a practice with 8 docs, who's paying fully insured rates, and it drops it in half. And so the important piece is when you're not paying $20,000 in premiums or $24,000 for your family, and it drops in half, or if you're a single doc, you have no wife, no children, nothing, or you have no spouse, no children, and it starts at $1,200 and it drops to $900, what happens is you take that excess cash and it goes to you. You put it in your pocket. The other thing we've been able to do is not only decrease all insurance expenses, so it's malpractice, key man, D&O, E&O, general liability, work comp, right? We only get rid of those. But then the other thing we've been able to do is renegotiate all the payer contracts. So in one state, we've got about 700 physician participants. Guess what happened? They're all of them except for one group is less than 20 docs. So guess what happened when we put them all together in one coalition?
You have a big force. You have a gang.
And so what I've been trying to do, whether it's for advocacy with Physician-Led Healthcare for America, or whether it's in these startups that I've built, it's all about uniting the docs, getting them to say, hey, I know that you compete on this level, but you don't need to compete here. You don't need to compete on human resources. Any policy book is a policy book. Right. Benefits aren't just benefits. Benefits, when compressed together, can save you a lot of money and you can have significantly better benefits.
Right.
And so there's no reason if you own an ASC and another guy owns 7 clinics, like, why don't you have one property line? Like, why do you want to pay independent? Why don't we just look at it and see if we can get quotes for less? And so this started in my brain about 3 years ago. And I just started talking to the docs I've been friends with for a long time. And I said, just entertain me and let me do it. Right. And we just started working on it. Then I hired some people, and we hired some more people. And we said, holy crap, this works. So now I don't think I can build it fast enough, but think about having 50 or 100 of these coalitions, if you will. And now physicians like you have decreased all their insurance lines by 50%, maybe more, right? It's more is possible. And now you've renegotiated your payer contracts. And now all of a sudden you go, hey, we got 3,000 doctors. Why don't we form our own network? And we'll sell our plan through the brokers to all the employers in New York. That's my dream. That's what I'm working on, and that's where I'm going. Because I've built every single component of that. Mm-hmm. And so it's a Braveheart that you said, unite the clans. And I'm like, no, unite the physician. Like, the best thing we can do is cooperate where we can, and then compete where we can to make sure that the patients are treated appropriately.
But I think there's laws that prevent physicians to do that.
No.
Stark laws.
No.
In the eyes of the government, we are competitors.
No, I've spent way too much money on lawyers, and we sorted all this out. So there's no.
So tell me,
imagine that's out there.
So tell me the structure of this. Is it like a clinically integrated network or a group without walls?
It's between an MSO, a GPO, and a PEO. And It's a new formed entity that works within that. And then what the magic of it is, I'm allowed to make it look, for the purpose of benefits, insurance, and payroll, to look like one entity. Right? So I don't have I can't tell you what to do. I can't tell any doctors what to do. The only thing that I have the right over, because you give me the right, is over these lines of insurance and over payroll. That's it. And what I can do then is I can add anybody I want. And if somebody says, hey, I don't want to be part of the group anymore, I can let them go. But the beauty of it is, when you create this organization, right, every single doc is an owner in this organization, every single one. And the other thing is, we're not just hedging, we're also building networks. And building networks is where we generate revenue, because the per employee per month fees that are generated by the carriers for processing claims can now go to the docs.
And let me ask you another question. So when let's dig down on, because you use a lot of acronyms that people might not be familiar with.
Sure.
So the payroll processing side of it, is everybody employed by your entity, or they're still employed like at the RBK level, but part of your entity?
Yes. They're all employed by us on this level.
Okay.
Only for the purposes of payroll and benefits and insurance. That's it.
All right. So that's what did you call that?
That's a PEO style of the business.
And what does PEO stand for?
Personnel Employed Organization.
Okay.
Yeah.
And then GPO is a group purchasing organization, which is, Pediatrician is very familiar with that model, because that's how anybody that's in business that has an IQ of 5 buys vaccines through a GPO.
Yeah. It's also how people buy medical supplies. It's how people buy lots of equipment. that you might need for your practice. Yeah.
And then you said a third component to it.
MSO, Managed Services Organization. So Managed
Okay.
Services Organization were made popular by management consultants in maybe the aughts, right? 2005, 2006. And they basically said, we can put entities in this group, and then we can manage multiple lines of things, whether it's GPO things, whether it's PEO things, whether it's whatever we want. You could literally put buildings in there. And what we can do is we can manage those services corporately for all of our member partners. And so it tightens up the employment circle.
Right.
And all of this is done, right? All of this is done by lawyers. Like, we could just the government could just let us do it. But because they create all these laws, like, we have to look within the law and go, well, okay, I can take a little bit from this one, a little bit from this one, a little bit from this one. And I'll just put this together, and then I'll just do it that way. Right?
All things cost a lot of money.
Huh?
Lots of legal fees, very expensive.
Oh, I've spent more on legal fees. So this is my 5th business that I've started, right? I've started 4 others, sold 3. I still own the other one. Started this 5th one. I've spent more in legal fees on all these businesses than I ever did, like hiring our first employees, buying computers, and it's always like, in New York, it was like, we want our money for your business license, and how are you doing this, and how are you doing that? But it's just, what's this madness?
Yeah.
It's silly.
So what's
Stop
the
making
name
it so hard.
what's the name of this company?
It's called Physicians Capital.
Physicians Capital. Okay.
Yep.
And then you're doing this and you're negotiating with usually United Healthcare as an example.
Yeah.
In the New York market, are you basically using a messenger model?
I haven't done it in the New York.
But where you're negotiating for fee schedules,
Yes.
you're using a messenger model?
More so than not, for sure.
But how do
Okay.
they negotiate with you? Because you don't provide clinical services. Why would they even negotiate? That's what always blows my mind.
It's the MSO, George. It's the
Yeah.
MSO. And the physician practices that belong to the MSO, if I don't like the Aetna contract that you have through your MSO, can I opt out, or you have to opt into all the contracts, everybody?
No, you can do. This is the beauty of this business that's taken me very long to figure out. Is you can do whatever you want. If you go, hey, we just renewed this deal. I don't like it. It's not for me. I'm an ENT, and I just find it not to be favorable. Then don't be in it. Right? It's the same thing when we launched our self-funded network. So it looks exactly like your health plan that you have, except at the top, there's a tier 1 network. So usually that's Cigna, United, Aetna, whoever it might be, right? But in this case, we framed it so that our network was number 1. So whether it's 200 docs, 500 docs, whether we have physician-owned hospitals and it's surgical hospitals, ASCs, right? All that's at the top. And it's no copay, no deductible. Then under it, you've got a traditional PPO. I'm hoping people don't use it. But when we did that, there were docs that said, I'm uncomfortable. Maybe UMR is not going to like me anymore. Or maybe Blue Cross Blue Shield of Illinois will hate me. I don't want to be a part of that. And I just went, then just don't be a part of it. You can opt out of whatever you want to opt out. This will not be a solution for every single person. The thing that I'm trying to get across is none of this is about the tools itself, right? This is not really about the robot in the office. This is really about, we have problems retiring. We have problems attracting new docs out of med school to private practice. We have problems with margin compression. We have problems with carriers. So and then we have regulatory problems, but let's take these 5. How do we begin to solve those? And the 2 of you, I know, this is just a matter of contemplation, right? Like a lifetime of learning and then thinking, okay, how do you begin to solve these problems? And that's where this Physicians Capital Benefits company came from, was we just wanted to think about what could work, right? Not exactly like this is the tool we must have, but here's the concept and here's what we want to try and do. My whole goal is to say in one state, I won't mention it, we are going to directly compete against the university system. And that academic system gets 623% of Medicare, and we're only going to get 260. And we're going to knock the deadlines up. Like, why would any employer want to do business with this academic health center when 80% of the population of those employers you utilize these independent practices, right? The physician-owned hospital, the surgical hospitals, and ASCs for a majority of their care. Like if they need some kind of inpatient services, oncology services, babies, like they've got a secondary PPO, and that will service them just fine. I think in the New York market, the Virginia market, DC, kind of Maryland, I think these are insightful tools. And I'm sure somebody will come see me and say, hey, how do we really do this?
I love your idea. And as a physician, we're always very negative. But the most difficult stakeholder is the physicians. You can tell a physician.
I'm glad you said that and not me.
No, I say this all the time. Okay, at the small level, at big level, I won't name the practice, but I just wrote a report for a practice, and I said, if you do this, you will make another $800,000 a year. That's gross, and you'll keep $200,000 off of it. It's not illegal. It's not bad medicine. It's just changing one process in your lab, and you get the partners twisting. I don't know. I got to look at the data because I don't know. No, what if they stop paying us? I got a contract for 3 years. And then you play hardball. If the insurance companies don't pay for that thing anymore, you go back to the vendor and you say, hey, they're not paying me the cost of using your machine. I'm not paying you. If you want to, go ahead and sue me. What are they going to start suing doctors all over the country? They'll go send us back the machine. Thank you. Or they'll lower their price on the supplies so that they can still sell because it's a market. I did the same thing with a practice, a single physician. I said, she's constantly complaining that she's not making enough money. I said, do this one thing, you will generate another $100,000 for your practice, of which you will keep 50%. I got to ask the medical assistants. They may not be comfortable with that. I'm like, do they own the business or do you own the business?
Yeah.
These stories are so incredible. I remember when I got started in summer of 97, I remember working on our first ASC, and one of my really good friends now I'm 49, he yelled at me and said, I will never, ever do procedures in an outpatient setting. I still remember him yelling it. And when he called me for my birthday, I tell the story. And I've told it to his wife and his children, and they're like, Uncle Dutch, he yelled at you like that? And I'm like, oh, yeah. Your dad did not believe in innovation, but the good news is he was highly conscientious, and he put the patient's ideas first. And I said, and that is a good battle, and that's why your dad and I are such good friends. Because we've always been able to say, here's a business idea, here's the medical side, which is why I have so many physician friends, and then we just begin to butt heads. And the butting of heads really creates the beauty of disruption in healthcare, right? Because you have all these tech bros. I lived in San Francisco for 2 years when I left New York. And this was my problem. They were building stuff, deploying capital, some tens of millions of dollars. And I would say something like, did you ask a doc? Has any physician been in this office to look at your workflows and what you're working on? No. And this is normal, right? This is very normal. These tech people just go, I know everything. I'm an all-knowing God myself.
Yeah.
They don't ask anybody that knows any question.
The best ones are the ones that get an MD, don't do like even an internship.
Yeah.
And then they go get an MBA and they go work for a big consulting company, say Deloitte Touch, right?
Yeah.
And then they come up with an idea and they raise $5 million and they're like, I'm a doctor. I'm like, you have no idea how pediatric practice works.
Yeah.
Let alone a surgical center or an orthopedic practice.
I love that you're calling him out, Dr. Bravo.
I'm a doctor. But no, you have an MD. You've never gotten your hands dirty. You don't understand how different every patient interaction is. Because I hate this. I love Six Sigma, but it doesn't apply to healthcare. Because no two human beings are built exactly the same.
Yeah.
Not even twins.
Yeah.
So there's a tremendous amount of variance in the exam room because every human being is different. And that's what's beautiful about a human being.
Yes, that's right.
But they're all different. So cookie cutter, zero mistakes, Toyota assembly line procedures do not work when you're taking care of humans.
That's right. But, well, I should say, and it can work. I remember one of my first projects in 98 or 99. I can't remember. That was a long time ago. I remember walking into these ambulatory surgery centers that we were developing. And really, the flow for the patients was really atrocious. And I remember saying, as an industrial engineer, looked at this, and God bless them, these two docs looked at me and go, "No, we did it all." And I went, "Okay, we got to rework how the patient gets from the front door, right, into the pre-op bay, into the procedure room or the OR. Like, we got to rework this whole deal because this isn't going to work." And so there are places where efficiency works, but there's a whole bunch to what you just said. And I hope people understand the nuance and the beauty of what you said, which is no one's the same. And we treat every single person as an individual patient.
Yeah.
Yes.
Like, no health system is ever going to say what you just said.
With practices, innovation is what can help practices. Because
Yes.
I'll give you medical scribes and AI scribes, right?
Yeah.
You know how many products there are out there?
A lot.
A lot. One is better than the other, and it's a computer guy that's giving you all these bells and whistles and many bells and whistles. When the doctor just wants something to write a progress note so we can move on.
Yeah.
It writes a good progress note. And it's not the most expensive one, is the one that you need. But at a healthcare system level, the guy that makes a decision on to what product to get is usually a guy that's computer illiterate and not using the product anyway.
Or worse yet, he's very computer illiterate. But no, he's very computer literate. He's very good at computer engineering.
Yes.
But he has no clue. He can't talk to a human being.
Yeah.
He can't. He's a genius. And we know someone like that. I'm not going to call her out on the air, but she's a genius. She can write you code to clean out your database any day. But she's a people person.
Or they need somebody in the middle to translate.
Yes.
But translate, then know some computer lingo to translate it to people like you. But another thing that happens with practices is, in a practice with a number of people, you can go and find a good product that will work in your organization and turn it on just like that. At a system level, you got to make a meeting to make another 5 follow-up meetings with a bunch of people, from nursing to the directors to the whatever, and make no progress.
Well, I think this is one of the biggest challenges. It's really good on some level, but it's one of the biggest challenges when you get large groups together. I'm in a practice, probably 2 practices a week. And one of the big challenges is when we do the partner meetings, there'll be 25 people. And the youngest partner will be 36 or something, and the oldest guy's 60. And it's just a battle of, not of wit, but it's like a battle of who's the biggest alpha. And I go in there and I really try to be the neutral party and say, okay, we have this problem and this problem. You guys are scientists. Let's solve these problems and not worry about, like, how much money is it going to cost, or what are the outcomes, or what is this, or what is that. Let's just try to figure out the straightest line we can to solve these challenges. And when you do that, all of a sudden, you start seeing some real progress. But I agree with you. It's really tough on a system level to get a bunch of docs to agree on something.
Yeah.
And the health system's got the lawyer, the chief nursing officer. My contract with Epic says that we can't bring that product unless they okay it. And it's just layers and layers. But to our earlier point about Six Sigma, there are places, particularly in the operating rooms, where you can develop Six Sigma, zero errors, which is, there's a hospital that only does hernia repairs in Canada. And everybody uses the same procedure, the same technique to get to the hernia. They use the same sutures, they use the same mesh, and the same protocols. You could do that for knee replacements. You can use the same implant. All the surgeons use the same implant, the same suture technique, the same approach, and the same team does nothing but knee replacements every day. And you do become very good at it because you take all the variants.
Yeah.
The sausage, the key, the art of medicine, though, is not that knee replacement, is the smart surgeon that knows which one is a good candidate for a knee replacement and which one
isn't. Yeah, that's right.
That's where the money is. That's where the meat is. The actual replacing the knee is wonderful because you can walk again, but knowing who's not going to be a good candidate for a knee replacement and who is and who's ready is what makes an excellent surgeon versus an average surgeon. And people don't understand that because it's very nuanced. I have a couple of more questions. I love the way you think. Do you know much about Paragon think tank in D.C.?
No.
I wonder if you knew them. And what do you think about Bill Cassidy, the senator from Louisiana? I think he has some good proposals as to how to benefit primary care providers within the system that is broken. At least he's thinking outside the box and cost and how do you change a cost curve.
Now, Cassidy, is he done? Is he finished?
No, he's got to run.
Got 2 more years?
He's got 2 more years.
Yeah, I heard he wasn't going to run again.
I understand that the attorney general, someone in Louisiana, is going to run a primary against them.
Okay.
But he's got some good ideas. I've heard him in some.
I do go to those terrible PAC meetings, and I was with him and Dr. Marshall, senator out of Kansas, last year in Sarasota, and listened to them both talk about it. As you may know, Senator Marshall is buddy with Bernie. And I got to hear Marshall and Cassidy talk about different primary care options. They proponents of DPC, which I like. I even think some people say it doesn't work at scale, and I probably argue against that. I think it works fine at scale. I don't see any employers that are in all 50 states that can't make it work. And if they can't, then just go, you're just doing it wrong, because it's totally a scalable enterprise. I think that you've got a lot of challenges in primary care. I'm not sure why we're not incentivizing more docs that way. What do you think?
The problem is that you have to go back into history. So Medicare was a program that was built to keep what they called elderly back then, 62-year-olds, because life expectancy was 65.
That's right.
Out of dying in the streets because they couldn't access care.
Yeah.
And they were dying from heart disease, cancer. And so the money, rightly so, just like they did with the COVID vaccine, was put for innovation and hospital care to keep you at the end of life from dying in the street.
Yeah.
And so they pay a lot for MRI machines, they pay a lot for the Da Vinci robot, they pay a lot for the ultrasound, for ICU care. All these things were not around in the 1960s. CT scanners, it's because the U.S. government decided to pay a lot for these things so that people would innovate. And what have we seen is that there is no longer people in their 60s dying in the streets of Chicago because they can't access care. And if they do get cancer, they get phenomenal care. Even the poorest person gets phenomenal care. But we're only spending 4.5% of the $5 trillion in primary care.
That's right.
And we haven't been able to pivot to 50% of the patients are seen in their primary care office. We can't just pay that workforce 4.5% of the bucket.
And why this gets me into a conversation about the RUC committee, right? The RUC guys. Why does CMS task these guys? I think there's 30 or 32. I have an interview with one of them in a couple of weeks, one of the members of the RUC committee. They keep lowering the amount of reimbursement that non-surgical docs get. And then I've never seen an increase since 1997 of the residency cap budget. And so why is it that way? I just don't, I guess my brain doesn't logically understand why we don't want more primary care docs. I think it's one of the hardest and most challenging jobs in all of medicine.
I think people want them. It's a budgetary problem.
Yeah.
There is no more money, and the people that make the money, and it's a pediatrician is lucky if they make $200,000 a year.
Yeah.
Okay. But a radiologist right now can work 2 weeks on, 2 weeks off, 6-hour days remotely, never leaving their house, and they make $450. So twice as much as a pediatrician, but they have 26 week off a year.
Yeah. No, that's true.
And so they have money and they have time to protect their turf. And the primary care doctor, I have friends who take 1 week of vacation a year.
That's insane.
And go to the office 5 days a week to see kids. And they're barely making $150,000 after 25, 30 years in practice.
This is why, though. This is why
and so you think that person's where's he gonna get the money to donate to a PAC, let alone travel to Sarasota, Florida?
Yeah. No,
to a meeting. They're not.
That's right.
The radiologist is like, yeah, I'm off those 2 weeks. What do I care? I already have $10 million saved up.
That's right.
And my kids are taken care of. The house is paid for in cash. I'm going to go to Sarasota. I'm going to talk to these people.
This is why after building surgery centers, networks for large employers, direct contracting companies, we built 2 of those. This is why I settled on this coalition business.
Yeah.
Right? Because I just said, we got to help everybody, including primary care. They're the ones that are dearest to my heart, and everybody that listens to me knows. They're the ones I like the most because they make the least amount of money. They get the most crap. But like that job is really difficult. Yeah. And health systems have placed them in a position where they're literally salespeople and referral docs. And I don't think that's a good use of their time at all. I don't think it's a good use of their time. And I think they're much smarter than that. And I think the only way to get them paid more is to get better contracts and to do better stuff with employers. And so that's DPC, that's direct contracting with employers, and that's building independent physician networks to get this done.
Yeah, I think you're absolutely right. And I think that primary care moves away from a volume, and I'm going to say it on the air, low quality. Because when you're doing 30 patients a day, you're not doing the best quality. It's just impossible.
It's possible. That's right.
Especially when you're doing primary care. One kid's depressed, the other one's obese, the other one's pre-diabetic, the other one's got ADHD. So it's not everybody's here to see whether they need a replacement or not.
No, Art, I've been with a DPC doc since 2012. The guy that I call the father of virtual primary care, which was, I think, the step 2 DPC, was Dr. Parkinson, Jay Parkinson, who no longer practices, was a pediatrician, practicing pediatrician, I might add. And he created Sherpa. And I remember thinking, like, this is the greatest thing of all time. And the docs that are like my personal DPC here in town, they don't see 6-8 patients a day. And they communicate with everybody. They go, hey, our group is maxed out. We appreciate your referrals. Your new referrals need to go to these physicians that also have a DPC practice. P.S., we're not getting paid for this referral, which I always think is funny. But I'm like, but hey, you know what? You've got your kind of cohort of patients and you're making enough money to live, and they're not making $1.50, right?
No.
They're doing really well. And that makes me happy because I'm like, you deserve to make a bunch of money.
And they have good relationships. When you call your DPC doctor, they know who you are.
When I text them, he's, come in on Friday. Great. No problem.
Yeah. See you there. Or do you want to get on a Zoom call? That makes a huge difference for people. They know who you are. It's not robotic. You're being treated like a person and a human being. That means a lot. You may not be able to cure them. That relationship is incredibly important to a human.
Yes, very important.
Relationship is what we always talk about. Just the podcast we did last week with the history of RBK, with the senior physician and the founders. What was the recurring theme from Dr. Kaplan and Dr. Raymond?
Relationships and community.
You know,
most important thing.
DPC is a great thing, I think.
Yeah.
It is a thing for people with money.
No, it's not.
If you got no money, you don't got it.
No, it's not. Both in Florida and Ohio, the Medicaid plans are getting into DPC. So they pay the pediatrician or the family practitioner or the internal medicine doctor like a DPC to take some of their Medicaid patients.
I mean, I get it, but look, let's be clear. Every innovation starts with rich people first, right? It goes from wealthy to rich to middle class to the poor. And the great thing about DPC is you started with concierge, right? Which for me in Manhattan ran like $3,800 a year plus my insurance benefits, right? Because they're big insurance. And now I'm paying $125 a month for myself, my wife, and my two beautiful young children. And so $125 a month is not out of the realm of possibility for the middle class. Now, if you make 30 grand a year, like combined income, you're not doing that. But look, DPC, the model's getting better every single year, and it's getting better. And I think it's the best chance we have for actually taking care of the people who need it most.
There's only one thing with DPC that doesn't work. So DPC is great. I think in no small amount because the person paying the bill is the person receiving the care. So they can vote with their feet. If I don't know how to diagnose you, if I'm not available, if I'm not affable, you can say, I'm done with her. I'm not sending him my $120 a month.
Yeah.
I'm going to go somewhere else. There does have to be a preventive public health component to that, which has to be paid by the federal government. And the reason is because humans are idiosyncratic. They'll go to the doctor when their knee hurts, but they won't go to the doctor to be told to lose the weight and do an exercise program before their knee hurts. They don't see the need to spend the money there. And that's a difficulty in the human behavior. People will address what hurts them. They're hungry, their needs.
Do you think part of that's inclined to them because there's no price transparency? Like we did a project at Walmart in 2012 in North Texas. And we had 17 or 18 Walmarts, right? That's a pretty poor middle class demographic. They opened physician clinics, one doc. It was $40 to get an appointment. And they put a big sign outside and said, we'll give you another 15% off if you buy groceries more than $50. It was amazing. And the number one piece of data I got out of that, the average person who came to that clinic had not seen a physician in 7 years. No medical appointment. And the number one reason they gave is because they saw a price and they knew what the exchange or consideration was going to be. And I found that to be profound, and I've not forgotten. It is seared into my brain. I know I've had this conversation with 5,000 docs at least about price transparency, and I still don't know why most independent practices don't have some form of price transparency available to common public.
They're afraid of it's not anymore, but all the contracts from the managed care companies forbid you from disclosing your fee schedule. Now that's hard to enforce because the Trump administration made it so all the hospitals have to disclose what they're getting paid for all the procedures, including their doctors that they hire, in a website. Now, George and I tried to go get the data, and it's a file that we couldn't break into.
Yeah.
And we couldn't, it's there, but
Yeah.
you can't see anything. You can't make it an Excel spreadsheet. You can't import it into Tableau. You got to go get Python and convert the data. We comply with the law, but you're never going to get it unless you're willing to spend 10 grand to look at the file.
No, you're right. We did a study on 125 of the largest health systems, and about 30 of them that we could access the data.
Yeah. And
well, that's crazy.
It's
crazy.
insane.
Yeah.
This has been a fascinating episode. Thank you for your time. I hope you come back and we'll dig
anytime.
politics.
I'm just sad it took so long to get together with you guys.
I know. We're sorry. It's just,
I got to make sure, though, when I'm in your parts of the country that I come see you.
Yes.
Yeah. When you're in D.C., let me know.
Here's the problem. You stay there, but I am actually in D.C. every month. So I'm just going to ping you and be like, hey, I'm here.
Yeah. No, do that. We'll get together.
All right. Sounds great. Thank you guys.
All right, Dutch.
All right.
Have a great day.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.